Hey everybody, welcome back to the ECG of the day. My name is Reed. If you enjoy this content, please feel free to like and subscribe to the channel. And before we get going, go ahead and go down to the description and download the PDF of today's ECG so you can follow along. So let's jump into it. The first thing we're going to do is look at the forest. Trees of the forest are my QRS complex, and so maybe I'll look down here in lead 2, and what you notice is we've got a wide complex rhythm that is very regular. If you look at the width of this QRS, it's quite wide, but it is occurring quite regularly, and if you look throughout this rhythm, it appears to stay just about that pattern. And so because of this wide complex, we start wondering, well, there's obviously some type of aberrant conduction through the ventricles, because if it was going through the normal His-Purkinje system, it would be a bit more narrow. Our rate here, if we kind of start on this QRS on the solid line, is 300, 150, 100, 75, 60, maybe 65 or so beats per minute, so it's a normal rate. And if you look just kind of glancing, I don't really see good atrial activity in front of these wide complex QRSs. So let's evaluate that a little further. So what is the atria doing? Are there P waves that are driving these QRSs? I don't really see any, right? And I don't see any hidden Ps that seem, if I kind of scan through the leads here, scan all throughout, I don't see any P waves. So we've got no P waves that are driving this rhythm. So obviously our sinus node does not seem to be, is what causing, if there is any atrial depolarization. Okay, so we're trying to work through, we've got this wide complex rhythm, what could this be? And so we might have to kind of change our approach to this ECG, because we're obviously not going to necessarily look at the PR interval, because there is no P waves to look for a PR interval in this case. So maybe we'll look at the QRS and try to characterize this a little bit better. So we said it was wide. We know it's wide because our QRS is greater than 120 milliseconds. And so this wide complex QRS tells me that we're not taking the His-Purkinje system. And when there's no P waves in front of it, this is likely some type of ventricular ectopic rhythm. And so because wide complex QRSs that are occurring from ventricular ectopy, right, if some ventricular focus fires off, depolarizes through the ventricles, it's going to take a very slow time as it's traveling from cell to cell throughout the ventricles, rather than through the nice His-Purkinje highway system. So these beats, if I look at them closely, they're wide complex. This is very wide complex. There's no P wave in front of them. So I'm going to say that this is not a junctional rhythm, right? Because a junctional rhythm would occur from the AV junction. If you zoom in here, it would be a rhythm that is from the AV junction that is causing ventricular depolarization. Sometimes junctional rhythms can be with aberrancy, but I don't see any type of predictable pattern, right? There's no right bundle branch block. There's no left bundle branch block in the lateral leads. And so because there's an absence of any well-known or understood aberrancy here that could explain a junctional rhythm, this is likely a ventricular ectopic rhythm. So this is a ventricular beat. If you look at the axis of my QRS, you notice that it's upright in all of the inferior leads. That ventricular ectopic beat is upright in these leads. It tells me it's going towards the inferior leads. So likely what's happening is there's some type of ventricular ectopic focus that is somewhere from high up in the ventricles, say somewhere high up in the ventricles, that depolarizes slowly through the ventricles towards the inferior aspect of this ECG. And so this is likely the cause of what's going on. So we've got ventricular ectopy, right? And so what is normal ventricular ectopic focus usually beats at 20 to 40 beats per minute, but this one is beating at 65. So what do we call that? We call that an accelerated idioventricular rhythm, or AIVR. Right? And all that's saying is that we've got this ventricular focus that's firing off, but it's not a ventricular escape beat. because escape beats would be 20 to 40 beats per minute. This one is faster, in between 60 and 100. So AIVR is going to be a ventricular ectopic focus in between 60 and 100 beats per minute. Now, sometimes in ventricular ectopic beats, you can have retrograde activation as well. This depolarizes, this focus is going to depolarize the ventricles all throughout the ventricles, and sometimes can send signal up the AV node, and that's kind of patient dependent, and it depends on the health of their AV node. It also depends if they have the pathways that are compatible with that. Sometimes after the QRS, you can actually look for retrograde P waves, and maybe we have some. If you look here, maybe that little notch, to see how sharp little notch just after the QRS, potentially that could be representative of a retrograde P wave. You can see it a little bit better in these inferior leads here. You can see this little bump, and P waves are usually sharp, and so there is a chance that that could be an ectopic, or excuse me, a retrograde P wave, as the AV node is conducting signal back, right? And we would expect these retrograde P waves to be negative deflections, which maybe is what this represents. So kind of plus or minus, but at the end of the day, what we know is that there is a sinus node standstill, right? So the SA node is not functioning, and we've got this ventricular rhythm that is taking over, right? Is the sinus node not functioning because it stopped and then AIVR kicked in, or did the AIVR cause these retrograde P waves that we just talked about that are essentially silencing the SA node? And so, because of this ectopic rhythm that we have identified, we can't really look for pathological Q waves because it's not taking the His-Purkinje system, so that it really isn't much of a factor here. ST and T wave changes is also the same. Why? Because we know that the T waves are caused by repolarization of the depolarized cells, and whenever the pattern of depolarization is altered, right, through an ectopic rhythm, some of these ST and T wave changes aren't really the most reliable, right? And so what's something that's interesting, I think, is just a good point to make, and if we look at this kind of cut axially through our ventricles, these right here are our fascicles, and they are carrying all this signal. It's a part of the His-Purkinje system, and notice they're in the endocardium. And when they depolarize cells from the endocardium to the epicardial layer. That's how they depolarize from essentially the inside to the outside, right? This is the surface right here. So that's depolarization, and repolarization actually occurs in the opposite direction. So that's why we have a very predictable ST and T wave based on our QRS morphology. And so when you have an ectopic focus, it's not following that path because there's some focus that's, here at the surface, and it's just depolarizing through all these cells. So because of that, you can't really get a great evaluation of our ST and T waves. So let's put this all together and, make our diagnosis. So we've got a ventricular ectopic rhythm at 65 beats per minute. We would call that accelerated atrioventricular rhythm, plus or minus retrograde P waves. What we do know is that there are no sinus P waves, so we can definitely say their sinus node is not causing atrial depolarization. When do we commonly see AIVR? AIVR is commonly post, excuse me, I didn't write that right, post revascularization of a STEMI. So sometimes people that go to the cath lab, they have AIVR as a common and benign rhythm for them. And sometimes people have this and they're asymptomatic, and some people have this because they just have ectopic focus and they need to ablate it in the cath lab, or in the EP lab, excuse me. So hope this helps. If you have any questions, throw them in the comments. If not, have a great day. We'll see you tomorrow.